Hey everyone, welcome to the first set of videos in our chest pain virtual round series. Please like and subscribe as it'll help our project going forward. With these videos, I'm hoping to provide you a baseline understanding of what is needed for our virtual round sessions. But just a quick tip, consider increasing your speed when you're watching these videos. It'll help you get through more material faster. So for this video, I'm going to be going over the H&P sheet. So what is this? The H&P, it stands for history and physical. It's what we do when we admit a patient to the hospital. So a patient comes in, they give you your chief complaint and everything like that, and you get the history from them, you do your physical exam, and you come up with your assessment and your plan. So the SOAP format is what we use to write our notes. So what does it stand for? S is subjective, and as you can tell, I'm very bad at writing. O is objective, A is assessment, and P is your plan. So with this, you get the general sense of why the patient is coming in. So the subjective material is what the patient tells you. So if the patient tells you that they have chest pain, that's subjective. If they tell you that they've been having shortness of breath, also subjective. Now, if you take the example of shortness of breath, if they say they have shortness of breath and you objectively see that they are breathing faster and breathing harder, that is objective information to back up their subjective claim. So what all of this means is that we are trying to gather information from the patient, from the patient's body, from our lab work, from our imaging to come up with the right assessment of the patient. So if we're saying a patient is coming in with chest pain and shortness of breath and they have signs and symptoms of a heart attack, our assessment is going to be this patient is coming in for a heart attack, which, yeah, makes sense. But when we take the overall picture of the patient, and you'll see in these cases, a lot of patients have symptoms and findings that can be consistent with multiple diagnoses. So we have to have a plan to bring all of that together and to decide what is actually going on with this patient. How can we pinpoint exactly what is happening to them so that we can come up with the right plan and actually help the patient out. So let's go through this worksheet. Now, the first thing we have here is the chief complaint. So the chief complaint is always the main reason the patient is coming in. So if the main reason they're coming in is their chest hurts, then that's chest pain. If they first come in and say, oh yeah, my foot really hurts, but then later on in the visit they say, yeah, my chest is starting to hurt, it's no longer foot pain. Their chief complaint, the reason why they're there, is the chest pain. So that's pretty straightforward. Now, the next section is the HPI. The HPI is the history of present illness. It's really a glorified way of saying, what is the patient's story? What are the factors surrounding the patient's condition? It can be organized in a ton of different ways, but most med students learn the OPQRST format. So let's go through this system. So when we talk about OPQRST, the first part is the onset. So when did the symptoms start? So they're going to tell you, oh, my chest started hurting 2 hours ago, so it'll be 2 hours ago. And then you want to find out, did it start suddenly or did it come on insidiously? So did it come on slowly and is slowly building up? And then you also kind of want to see if there's any provoking factors, anything that they were doing prior to that. So that is all encompassing in your onset statement. Next is the provoking factors, the palliative factors. Generally, all that means is what made it better, what made it worse. And those are really important for something like chest pain, because if someone tells you that my chest started hurting after doing exercise, well, then is your heart not able to keep up with the exercise you're doing? And if so, well, crap, we're probably thinking something along with the heart. So it is very important to know what is making it worse. The other side of that, though, is what makes it better. If the patient tells you that my chest is hurting, but it gets better with Tylenol or ibuprofen, yeah, that's not your heart. Your heart is going to have pain because it is dying, not because there's inflammation or because your muscles surrounding like your rib cage are in pain. So the factors that make the pain better are very, very important as well. Now, the next one is quality. So how do they describe the pain? Is it dull? Is it sharp? Is it achy? Does it burn? With chest pain, most of the time it's when you think about the heart, it's going to be pressure. That's that phrase that you see that the patient states that it feels like an elephant sitting on his chest. It's that pressure and tightness. Now, when we think of something like burning, if you guys know what shingles is, shingles can cause chest pain if it's in that distribution. It's a rash caused by the same rash that causes chickenpox, but you get a distribution of that rash in the chest. It can cause burning type pain, and sometimes you get the pain before the rash comes on, and so people will come into the ER saying, "My chest hurts," and we work them up, and everything is negative for a cardiac cause. But then 2 days later, they burst out in this nasty looking rash, and it's like, wow, they actually had zoster. So it's kind of cool. But the most important thing is finding what the actual type of pain is, because that will help you determine different etiologies. Now, having said that, when it comes to chest pain, the majority of the studies that we did to actually categorize chest pain as something that's cardiac versus non-cardiac were actually done in white males. So that's why you have women and people of color, and especially older people, presenting with quote unquote atypical findings, when in reality, they're just not typical for white males. So that's a little bit of an aside that I found interesting. And when you guys get to admitting patients, whenever somebody has weird symptoms and they have risk factors for having a heart attack, don't brush that off. Trust your gut. So radiation is super important because it gives you clues on different causes of your pain. Now, with chest pain, everything that is in the chest can cause pain. So the outside of the chest, the muscles, the bones, all of that can cause pain, but the insides as well. So we all know this because dying heart causes pain, which is the pain that you feel with a heart attack. But if we look here, the lungs are also in the chest cavity, and forgive my crappy drawing, and that can cause pain as well. So it can cause pain if there's injury to the actual lung or into the lining of the lung called the pleura. Now, aside from the lungs and the heart, you also have the aorta. Now, one of the classic things that we see in when we're trying to figure out a differential for chest pain is that patients that have ripping and tearing type pain that radiates to their back, a lot of times it's caused by aortic dissection. And what aortic dissection is when there's a disruption in the lining of the aorta, sometimes blood can start flowing into that disruption, and it causes kind of like a pouch going all the way down. And so if you've ever done anatomy and you've dissected something, it's the same thing where you're dissecting between those two layers and causing that false pouch. Now, that is dangerous because one, it weakens the vessel, and two, if it's big enough, you can spill a good amount of blood in there. But the more worrisome thing is what happens with that thickened, that weakened vessel. If it rips, well, all of your blood goes through the aorta, and so there goes all of your blood supply. So you're now starting to spill it into different cavities. You can spill it into your thoracic cavity over here, or if it's lower down and you start dissecting down here and it breaks, that can cause blood into your abdominal cavity. Now, the last thing that I put here is this green line here is your esophagus. Now, your esophagus can cause a lot of pain too, especially people that have something like reflux. That reflux is going to cause burning sensation down here, which can feel like chest pain from your heart. And so knowing how the pain radiates is very important in its categorization. Now, next is severity. Now, severity is a tricky one because a lot of patients will tell you they have 10 out of 10 pain. A lot of them will come in and say, yeah, doc, I have 11 out of 10 pain. And it's like, are you sure? Because the way that we categorize severity is that if you're 10 out of 10 pain, that's like you're crying and dying and you need to be in the ER because you can't stand it. The way that I like to tell people is that, one being the just very light pain, 10 being the worst pain that you ever felt in your life, plus a bit more. And so you tell them that sometimes patients will say, yeah, this is still a 10 out of 10 when they're sitting comfortably, they're talking to you comfortably, and it's like, I don't really know. But that's the problem with these subjective tests, because every person's pain is personal to them. So Having said that, I do find severity sometimes is not as helpful unless you have someone that's visibly in pain and what they're telling you correlates. Then that is more helpful. And lastly, we have timing. Is this pain constant? Is it intermittent? For how long is it happening? So if we take the example of chest pain again, if you have chest pain because your heart is dying, do you think that it'll be constant or intermittent? And if you're thinking it'll be constant, you're right. Because, your heart is actively dying and you're not going to have any relief of the pain while it's actively dying unless we do something about it. And so that's why timing is super important, because if someone tells you that they're coming in with chest pain, they're worried about that it's their heart, but they tell you, yeah, it started about an hour ago, it got better for like 20 minutes, and now it's back, and now it's getting a little bit better. Yeah, that might not be their heart. You never want to discredit it completely because people present weirdly for cardiac chest pain, but it gives you more clues. And then all of this coupled together gives you a good history of that person's problem. And you use that history to try to figure out what the next steps are. Now, what I tell everybody is that the history is king, meaning if you are able to get a really good history, you can more or less figure out what's going on with that patient. What I tell all of my interns is that when you go through a patient's history, it should help dictate what you're going to do next, what you're going to be focusing on for your physical exam, what you're going to be focusing on for the imaging in the labs you have to order, because your history is a really good guide. Now, it takes time to develop the skills to get a good history, and it takes time to know what questions to ask. And that's why we have these symptoms of OPQRST, and we guide medical students by telling them to ask these questions. But this system is only really good for pain-based questions, because if you have somebody coming in with nausea, well, how can you give a quality to your nausea? Like, is it regular nausea or is it not regular? Like, you can't give that. And then nausea doesn't radiate, so what do you do then? And so a lot of times medical students will get really comfortable with the system, and when somebody comes in with something different like nausea, they get lost. They don't know what to ask. And so this is a good starting point, but what I tell everybody is that your history taking, for the most part, should be logical. If a patient tells you that they have nausea, well, what are some things that can cause nausea? If you eat bad food, that can cause nausea. So, hey, what did you eat last? Did you eat anything out of the ordinary? Did anybody in your house eat the same thing and now they're feeling sick? So those are all, having that logical kind of next step approach can help you in those situations where your algorithm doesn't really help and it doesn't tell you what to ask next. Now, I spent a lot of time on the HPI because I feel that it is very important, but let's move on. Now, the past medical history is what it sounds like. It's your past medical history. What chronic diseases do you have? Do you have hypertension? Do you have diabetes? Do you have osteoporosis? Whatever it is that goes there. In addition to that, you also have your previous hospitalizations. So that's important if somebody has asthma and they are coming in because it looks like they're having an asthma exacerbation. And it can help you guide, should that patient be admitted, for how long can we expect them to be in the hospital, all that stuff. And then the other one in the past medical history that I like to ask is immunizations. Now, I only really ask that if I'm dealing with something that is pertinent to know. So if somebody's coming in with chest pain and I'm thinking, shingles, well, did you get your shingles shot? And if they say yes, maybe not so much shingles. And same thing, if a kid is coming in with a weird rash and I'm thinking, can this be measles? That'll help dictate, the immunizations will help dictate how worried I am about something like measles. And then in the past medical history, we can also ask gyne questions. And if you have a young woman coming in with abdominal pain, and it's lower abdominal pain, and they missed a period, and now they're bleeding and they're having a lot of pain, well, you better be worried about an ectopic pregnancy, because that's something very dangerous. So in the gyne history, you would ask the last menstrual period. You'll ask if they're using any contraception, and so on and so forth. And this lesson isn't teaching you how to do specific history taking skills, but the gyne history is important for women in general. So same thing with an OB history if you're dealing with anything OB related. Now, the meds. The meds are very, very, very important. If I have an intern that presents a case that doesn't know what medications they're on, the patient is on, that's an intern that didn't do their job, because the majority of the things that we see come in the hospital are due to medication errors. Either they're taking the wrong medicines, the patients were prescribed the wrong dose, or they took too much, something like that, or they're taking the right dose and now they have a side effect. So meds are super important because of that, and I always tell everybody to focus on the meds. If you have no idea what's going on with the patient, well, if they're coming in with, I don't know, with dizziness, well, check the meds. Did they recently get started on a new blood pressure medication and now their blood pressure is tanking? Or they're coming in altered. Did they start on a new diabetic medication and their blood sugar is really, really low? So the meds will actually help out a lot, especially if you're stuck. Allergies are important for just knowing, what the patient's allergic to. I hardly have allergies be what is actually causing the patient's problem, unless it's like a rash or they're in full-on anaphylaxis. So the allergy is important, but not super, super important for medical decision-making purposes. Past surgical history is another kind of important topic, but not crucial. So past surgeries are important for if somebody's coming in with abdominal pain. Well, yeah, have they ever had abdominal surgeries before? If like they're having abdominal pain and you're like, well, is it the gallbladder? And you present to your attending, which has happened to me before. I'm like, well, I'm worried about a gallbladder stone or an infection in the gallbladder, and the attending's like, yeah, did you actually check the history, because she had her gallbladder out like 10 years ago. So it's important to look at. I wouldn't spend too much time on it, because a lot of times they have something like hernia repairs or something like that, and those aren't really pertinent for the majority of things that we're seeing. Family history is another section that can be pretty important. Usually I see that for something like chest pain, did their father have chest pain and have a heart attack when he was 40, and now the patient is 42? Well, yeah, then this might be a heart attack. Same thing with strokes, same thing with cancer is another really big one. If there's a huge family history of cancer and this patient's coming in with a new breast lump and their mom had breast cancer, well, I better be more careful and be more thorough to make sure she doesn't have cancer. So family history is actually really important. But a lot of times I don't see it really dictating my medical decision making unless it's really straightforward and connected, like, cancer. Now, the next section is social history, which is actually really important, because a lot of what we do to ourselves gets manifested into disease. So tobacco, for instance, can cause things like lung cancer. It can cause heart attacks. It can damage your vessels, so you're more prone to building plaque and clotting and all that. So it is important to get this history. Same thing with alcohol. We see a lot of patients with cirrhosis because of alcohol. And in addition to that, we have people come in for withdrawal. So if somebody is altered or somebody's having a seizure, well, you better think of alcohol withdrawal, and you should get a alcohol history from them. Drugs, in my area, we see a lot of heroin. We see a lot of methamphetamine. Not so much cocaine. And cocaine is one of the things that can cause a heart attack. But you should, when you're in med school and when you're in residency, you should be familiar with what is going around in your area. We had a period of time where we were seeing a lot of hallucinogenics, but this was back when I was in med school, and I don't know if it was just anecdotal, but I had to kind of look into that, so it's important to know. Now, I also include diet and exercise, and that might be the family medicine doc in me, but I like to get a general idea of how active they are and what they're eating, because a lot of times that factors into their health. And if it doesn't now, if they're coming in for a heart attack, well, we better talk about diet and exercise, because it's going to help. It's going to dictate, what their longevity is in life, and what their life quality is going to be. Occupation is super important, especially now with COVID. Your occupation is going to dictate a lot of, your health. So if you're somebody that sits in a desk all day, you're pretty sedentary, and you're not getting a lot of exercise, well, you're at higher risk of developing diseases like diabetes, like hypertension, just because you're not as active as somebody who is active for their work. We developed from nomadic people, basically. So our genetic makeup and our bodies are used to and want to be moving, and we unfortunately in our society don't have that. So occupation is super important. And as far as COVID goes, I'm asking everybody: are you currently working? Are you living with anybody that's working, and all that, because it'll help distinguish what my suspicion is for COVID. And then sexual history, super, 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 super important, especially if you have somebody that's young. And obviously, you're not going to ask sexual history on everybody, but sexual history is important because, a lot of young people can be pretty reckless, and so any weird rashes, any new vaginal discharge, or like penile discharge, or really any weird genital urinary symptoms, I ask a sexual history, because STDs can present in weird ways. So actually the correct term I think now is STI. So all right, and the next section is the ROS. The ROS stands for Review of Systems. And so this is what the ROS is when we see a patient, we ask all the history and everything like that. We then ask for any associated symptoms. So if the patient's coming in with chest pain, we ask if they have shortness of breath, if they have palpitations, all that. And then we go dig a little bit deeper. So are you having any dizziness? Are you having palpitations, orthopnea? These are all symptoms associated with the chest pain that can push us in different directions as far as trying to figure out what is causing the pain. But then we can ask something like, GI pain. Is their belly hurting? Are they vomiting blood? Are they pooping blood? Are they just really constipated and it's causing pressure to build up into their chest cavity? Are they just having gas because they're eating gassy foods? So, are they having bloating? So things like that. So we ask for any other symptoms that may be associated with their present illness, and they should be pertinent. So if somebody's coming in with chest pain, I'm not going to really ask them if they have symptoms of like a bladder infection, like it's burning when they pee. When you're just starting with the ROS, it's good to have a big list like this where you ask a bunch of different things, but you want to narrow it down once you have a better feel. And then having a big list like this, especially in our sessions, will help you kind of remind you what to ask. But it is important after you get used to this to start focusing on what's more important, because you don't want to waste your own time with the patient when you're going to have like 5 other patients waiting for you to be seen. So all of this is subjective. This is what the patient is telling you. So it's what the patient is feeling, is what they're telling you. Now we're going to move on to the objective part. So that's your physical exam, but we start with the vitals. So I will put a short video on what the normal vitals are, but generally we look at temperature, we look at blood pressure, we look at pulse, we look at respiratory rate, we look at O2 saturation, and then we also sometimes look at height and weight. This, not so much, but these are really important. And vital signs are vital. If you don't know the vital signs, you probably miss something really big with the patient. Or, you hope you don't, but there's a possibility you do. Because if a patient is coming in with chest pain and their vitals are stellar, they're rock solid, there's nothing wrong with them, well, they might not have anything going on that will kill them in the next hour or so. But if you have a patient that's coming in with chest pain and their blood pressure is super low and their pulse is really high, well, they might have a massive pulmonary embolism and they might die in the next hour. So vitals are really important to look at and to be comfortable with what the normals are. You don't have to memorize it for this, and you can always have your notes with you while we do our virtual rounds. So this is not anything you need to memorize, and really you shouldn't be memorizing anything for our sessions. As you guys get to know me, you'll know that I hate memorization because I'm terrible at it, so I would never expect that from you. So after the vitals, you do your physical exam. Now, the physical exam is going to be hard to kind of go over in a video like this, so what I was planning to do is go over it by systems, and we can do that as we go through some of the systems. So now that we're talking about cardiology and chest pain, I'll put a video out about the cardiac exam. But in general, you want to have a system when you're going through a physical exam. So you want to you go head to toe, or really any system that works for you. For me, it's always easier to go head to toe because it's what has worked for me in the past. So I look at them generally. How is it that they look? They look good? They look slick? Are they talking to me? Are they responsive? And if all of those questions are yes, I go on to the next thing. So look at the head. Are there any issues with the eyes or any issues with the mouth? And you can do it that way in general terms, like, oh, yeah, they look fine in the head. And you don't, if it's something like a heart problem or a belly problem, you might not need to go super thorough into the HENT, so head, ears, nose, and throat. Next is neck. So there's a lot of structures in the neck. When it comes to chest pain, most likely you're looking for the carotids and seeing if they have, seeing if they have venous distension. That will tell you that they're backing up fluid, and they might have some heart failure. Next is cardiovascular, and then in this one it says breast, but really the cardiovascular system is what I usually do for every single patient that comes in. I listen to their heart and I listen to their lungs, and in the cardiovascular, you're listening to how the heart sounds, and I'll go over this more, but generally you're listening for murmurs, you're listening to see if their heart rate is regular, if they're having any arrhythmias, which is abnormal rhythms for the heart. Respiratory, listening to the lungs, obviously, and what you want to listen for is do they have normal breath sounds? Are they having crackling sounds? Are they having like wheezing or snoring type sounds? All of those will tell you there might be something wrong with the lungs themselves. And then generally when you look at a patient, if they're breathing comfortably, that's a little bit lower risk, but they can have pathology inside their lungs and be breathing fine. But if they're like really struggling to breathe, you see them like retracting, you see that they look like they can't get a good breath, you got to be a little bit more worried about the patient. Okay, now labs. This is something that a lot of residents and students struggle with. Not so much like the interpretation of labs, because a lot of times the lab will give you normal values and it's easy to see which ones are abnormal, which ones are not. What they struggle with is figuring out what labs to order. And it's important to know what labs to order so that, one, you're not wasting money. So we live in a society where the medication costs and the cost of healthcare is skyrocketing for those living in the US. So knowing which labs to order is super important. So generally what I like to do is order, every time I order a lab, is ask, what am I looking for this? If I have somebody with chest pain and somebody asks, well, why are you getting that? Well, if I'm getting a CBC, which is a complete blood count, that includes a white blood cell count, which is a sign for inflammation or infection. It includes a red blood cell count, which tells you if that person has anemia or they have something like polycythemia, where there's an abundance of red blood cells. And it tells you your platelet count. Now, for chest pain, for instance, if somebody's white count is really elevated, well, that might mean they have a pneumonia. So the CBC is going to be important for that. Next is your chem panel, your basic metabolic panel. So that is your electrolytes. You also have your BUN and creatinine, which tells you how the kidney function is, and you also have your glucose, which is your glucose levels. It tells you if it's low. The complete metabolic panel also has your LFTs, and your LFTs are your liver function tests. It tells you, is there any inflammation in the liver? So these two tests are generally ordered for everybody. The LFTs I tend to order if they have some type of abdominal issue going on, so just to make sure that there's no inflammation in the liver. I'll put a video together on what labs we generally order for cardiac patients, but in general, these two are what we generally look for: the CBC and your basic metabolic panel. And I will go over what these are. These are our shorthand notations for your lab. So this is the CBC, and this is your basic metabolic panel. And I'll go over that when I talk about the labs that we do for the cardiac cases. Now, imaging is also another area that people struggle with. Once you get used to it, though, you know what things are used for, it becomes easier. But I think labs and imaging are hard because you have to actually make some decisions, like, is one test better than the other? Imaging, for chest pain, we typically order a chest x-ray, and then from there we kind of branch out. Are we thinking a pneumonia that we can just treat? Then great, we don't have to do anything else. But if we're thinking of pulmonary embolism where there's a blood clot sitting in the pulmonary artery, well, we get something called a CTA, so CT angiogram. And so the blood that's flowing in here on both sides can get blocked because there's a clot. And when the clot is huge, you actually cut off blood supply to the lungs. And if the lungs can't get blood, that means the other side of the heart can't get blood. And if the other side of the heart can't get blood, well, you're not pumping any blood. So that's something that we get for somebody that comes in with like shortness of breath and chest pain, and their blood pressure is low. And they have some reason they might be hypercoagulable, meaning they're making blood clots. So imaging, like I said, is hard because you have to make those decisions. Well, chest x-ray is easy. Most people get a chest x-ray. You'll probably have a chest x-ray waiting for you because the ER sometimes reflexively orders it. The CTA pulm, if you're thinking about a PE, a CT in general with contrast of the chest is helpful if you're thinking something like a malignancy, so like cancer. So that's generally what we do in the the echocardiogram. The echocardiogram is a ultrasound basically of the heart that shows you each of the chambers of the heart, and you can also look at the valves of the heart. You can assess if there is a clot in the heart itself. So this is super important, and we get it for people that are complaining of cardiac symptoms, but also with a stroke, and we'll go over that in the future, probably for one of the neuro cases. And lastly is the EKG. So the EKG, it takes a long time to get good at EKGs. In all honesty, I don't think I'm amazing at EKGs, but we'll review kind of the basics. But in anybody with chest pain, you want to get an EKG because the EKG will tell you if the patient is acutely going into a cardiac event. So if a patient comes in with chest pain and everything looks okay and their EKG looks good, it's a normal signal, well, and it might not be cardiac, but it still might be, but probably not. But if they come in with something like this, where you have this tombstone, this is a really bad drawing, this tombstone-like appearance where, I know why it's a bad drawing, where it looks like, there it goes, where this looks like a tombstone, right? That is something that's very concerning for a heart attack, and it's called an ST segment elevation. And so you've probably heard of a STEMI before, and this is what a STEMI is. It tells us that there is complete blockage of a vessel, and you're having full thickness ischemia or basically cardiac death, because that part of the heart is not getting enough blood, and it causes this signal on the EKG. And so EKG is super important to ruling stuff like that out. It's not super consistent. You can have cardiac issues without having ST elevations like this, but the EKG does give you clues. So all of this is your objective material. It is what you gather from the patient by examining them, by getting labs, by getting imaging. And so with all of this, with the subjective and with the objective, you then go into your assessment and plan. And this is why you are a doctor. This is what you are paid to do. You are paid to think. And so you gather all this information and you synthesize it into an assessment of the patient. So if a patient is coming in with chest pain, it's not enough to say chest pain, I think it's a heart attack, we got to treat him. Eventually you'll get there, but for most medical students and residents as well, you have to give a good reason why. So for somebody that's coming in for a heart attack, I would say, well, this is a 57-year-old patient with a history of coronary artery disease who came in with 3 hours of chest pressure that has not improved, that first started after exercising and has not improved. Was brought in by ambulance to the ER, found to have ST segment elevations on EKG, and troponins were elevated, admitted for cardiac catheterization, something like that. So that is your assessment, and then your plan is what you want to do for that patient. So in this example, I talked about GERD, which is gastroesophageal reflux disease. So it's basically reflux and heartburn. And so the assessment is like likely GERD given symptoms of reflux and heartburn, when patient feels chest pain. So that tells you, it's probably not cardiac if they're feeling heartburn at that time. Improves with Tums. If their chest pain improves with Tums, it's probably not cardiac. Not likely cardiac. It's not associated with activity, and you can talk about, no significant risk factors for the patient, blah, blah, blah. So the plan for that patient is mostly like lifestyle. So avoid spicy foods and coffee. Mint also can cause reflux. Exercise regimen, because obesity can cause some reflux if that patient is obese. Pepcid is a type of antacid, not actually an antacid, it's a different mechanism, but you get what I'm saying. And follow up in 2-3 weeks if no improvement. So that's going to differ from somebody that has chest pain due to a blocked vessel causing coronary artery disease and a STEMI. And that person is going to go to the cath lab and get that blockage corrected and put a stent in that artery. So I put this together. I adapted it from one of the ones that we have here at the hospital, but I put this together so you guys have an organized way of going through these cases. So when I give you your practice case, I want you to go over it just like this. So go through the chief complaint, get the history of present illness, look through the past medical history, look through the past surgical history, do all of this and write it out like you're going to do an actual case, because I want you to get familiar with this format because it'll guide you to what the next step is. If any of this doesn't make sense, feel free to reach out and let me know. I am here to help you as much as I can, and if you have any questions, my contact information will be below this video. Please like and subscribe, like I said before, because it will help this project a lot. And if you have any recommendations or ideas for anything in the future, please let me know. Okay, thanks.